Hey, Tiffany, I see you there. I'm going to hold you on deck until it's your poster turn. Okay? We'll be starting in just a minute for those of you guys who are logging in. Hey, Lynn, I see you on deck. I'm not including you on the screen because I've got a limit, but I'll get you on here in just a second. If you can mute your mic while you're waiting, and then we'll go through each poster at a time. Okay. I'm just sending out a little tweet to let people know we're here. All right. Andrew, I see you there. We will get you on in just a second. Just sit back and watch for a little bit. We're going to start with Lisa. And then I'll get you guys on one at a time here. Okay. Welcome to the American Society of Regional Anesthesia and Pain podcast. I'm your host, Raj Gupta. And we are coming today talking about some of the abstracts from the ASRA Spring 2020 meeting that we were going to be having right now. And we can't this year. So we decided to do some of the posters online through this live virtual meeting setup. And for today, we're going to focus on the best of meeting abstracts and the Resident Fellow Award abstracts. And so we wanted to make sure you guys got an opportunity to hear from the poster presenters and talk about it with some of our faculty. Before we get started, I'm going to make a couple of notes. We're not going to talk about COVID-19 today, so you can take a break from that. We don't have to think about that for the next hour. These are preliminary research presentations presented as abstracts for a meeting, so they haven't gone through full peer review. Please take all the information as such. Be kind in your commentary. We want you to put comments in, but this is not, we're trying to look for constructive criticism. We're not trying to shame or badger anybody. This is all works in progress. Another thing, none of the faculty here have any conflicts of interest to report related to these posters, and so shouldn't be a factor. And I think that's the main introduction parts. Last thing I want to mention is that if you go to the ASRA.com website, please do go register for the webinar next week. It's going to be on Wednesday at 7 p.m. We're going to be talking, this is my last mention for COVID-19. It's a topic about how to consolidate the information about reopening your practices, your ORs, your pain practices after COVID-19. So that's going to be the focus of that webinar. Nabil, who you'll see here in just a moment, has put together a really great panel of speakers to talk on this, and I think that you will really enjoy the session. You do have to register for that one. That's going to be on a different platform than this, so go to the website and go find the details out for that. Without further ado, I'm going to pull up our faculty here so you can see them all on screen. We've already got some people watching. Hello, everybody. You can wave. We'll let them talk in a moment here. You can see their names down at the bottom. Let me take this little logo off so you can see everything properly. And our first speaker today is, we're going to start shortly with her poster. For those of you, the other authors down on deck, I see you. I know you're there. I'll get you on in just a moment. If you can bear with me, we're going to go through these one at a time. But thank you, everybody, for taking the time out and coming to present your work. Lisa, welcome. Lisa's from Stanford, and we're going to put her poster up here first. And this is poster number 790 if you're looking for it on the abstract website. And I'm going to put the link up here. Let me just pull the right one. And Lisa, it's all yours. Go for it.
Okay, great, thanks. So this is a research project done as a fellow at Stanford. This was a randomized trial looking at the erector spinae plane block for total shoulder arthroplasty as a phrenic-sparing alternative to the interscaling block. So we currently don't have a block that provides both adequate shoulder analgesia and is completely diaphragm sparing. And the interscaling block is the most common block for shoulder analgesia, but it can cause up to 100% incidence of phrenic nerve palsy and a 9 to 12% incidence of dyspnea. So the high thoracic erector spinae plane block is a more recently described block. It has only been reported in case reports so far as providing effective analgesia for the shoulder region with no phrenic nerve block. Our study looked at the high thoracic erector spinae plane block catheter, comparing it to the interscaling catheter in patients undergoing total shoulder arthroplasty. And the primary outcomes of this study included incidence of hemidiaphragm paresis in PACU and median pain scores through post-op day 2. So this study was done with IRB approval, and we also registered it on ct.gov. We had 2 primary outcomes. The first was hemidiaphragm paresis, which was determined using ultrasound measurements of diaphragm thickness at end inspiration and expiration. And the percentage increase in diaphragm thickness from expiration to inspiration was compared in PACU to the pre-block baseline measurements. So hemidiaphragmatic paralysis was categorized as none, partial, or complete. None was defined as 0 to 25% change from pre-block. Partial was defined as 25% to 75% decrease from pre-block to PACU. And then complete was defined as more than 75% decrease. And then our other primary outcome was median pain scores, which was looked at from PACU through post-op day 2. Our secondary outcomes included change in incentive spirometry volumes, motor and sensory function, opioid consumption, and activity and mobility score, which is already routinely assessed by our physical therapist on post-op day 1, adverse events, time to PACU discharge, and patient satisfaction with the block. And then in terms of the study time course, so preoperatively, baseline pre-block measurements were done by research assistants. The patients were randomized in a 1-to-1 ratio, and both patients and research assistants that were collecting the data were blinded to the type of block. The regional anesthesia team then placed the assigned catheter and bolused it with 10 mLs of 0.5% ropivacaine. Intraoperatively, all patients received general anesthesia with an ET tube. And then on arrival to PACU, the perineural catheters were all bolused with 5 mLs of 0.5% ropivacaine to basically reset the block and account for any variability in surgical time. And then 30 minutes after this PACU bolus is when our PACU measurements were done. And then postoperatively, all patients were followed as by routine by our acute pain service, and they were all run on intermittent automatic boluses of 0.2% ropivacaine. So the interscaling catheters got this at a rate of 6 mLs an hour, and the ESP catheters received this at a rate of 12 mLs every 2 hours, given that this was a fascial plane block. So figure 1 is the flow chart for our study participants. 30 patients were consented, and subsequently 2 were excluded, one because of delayed patient disclosure of chronic opioid use, and the other because of possible underlying cardiopulmonary disease, which was determined after seeing them in pre-op. So that left 28 patients to be randomized, with 14 to each group. 2 patients in the ESP group were not included in the final analysis because one patient was unblinded just before the block was placed. And then in the second, the ESP catheter was unable to be threaded in the plane to a satisfactory extent, so they were removed from the study. In the interscaling group, one patient had ptosis and the infusion was paused, and then another needed a decrease in their infusion rate because of dyspnea. And in the ESP group, there was one patient whose catheter was adjusted by pulling it back by 5 centimeters in PACU with subsequent satisfactory pain relief. In terms of our results, so I'll start by saying there were no significant differences in baseline characteristics between the 2 groups. And then figure 2 shows hemidiaphragm paresis. The high thoracic ESP group had no partial or full hemidiaphragmatic paralysis compared to 100% incidence in the interscaling group based on our ultrasound measurements. Figure 3 shows median pain scores. In PACU, the median pain scores for the interscaling group were significantly lower compared to the high thoracic ESP group, with an average median score of 1.3 for the interscaling versus 3.8 for the ESP group. But then subsequently from post-op day 0 through 2, there were no significant differences in pain scores for the 2 groups. And then figure 4 shows opioid consumption. So there was no significant difference in cumulative opioid consumption through post-op day 2, but the opioid consumption on post-op day 0 was significantly higher in the ESP group. And then in terms of additional results, there was a greater decrease in incentive spirometry volumes for patients in the interscaling group. So in PACU compared to pre-block, their volumes were decreased by 44% compared to 9% for the ESP group. And this difference was still seen on post-op day 1, where the incentive spirometry volumes for the interscaling group were still decreased by 38% versus 7% for the ESP group. There was also a 57% incidence of partial or full motor function loss in the interscaling group compared to 0 in the ESP group. And there were more adverse events in the interscaling group, with overall 29% of patients experiencing some adverse events compared to 0 patients in the ESP group. So in the interscaling group, this consisted of 1 patient who had dyspnea, 1 with hoarseness, 1 with Horner's syndrome, and 1 who reported subjective difficulty with PT due to motor and/or sensory block. And then there was no difference in time to PACU discharge, mobility scores on post-op day 1, or patient satisfaction with the block. So in terms of limitations of this study, it was only powered to detect a 50% difference in hemidiaphragm paresis, and it was not powered for the other outcomes that we looked at. There was no placebo control group because our standard practice is to provide an interscaling catheter for this surgery. And it would also have been interesting to consider measures of post-op functional outcomes rather than just focusing on pain scores and opioid consumption. I also wanted to mention that the high thoracic ESP technique is newly described, and it can be challenging, as we found with 1 patient in whom we were unable to thread the catheter to the appropriate level. So this demonstrates that anatomical fascial plane anomalies can affect this block. In conclusion, the high thoracic ESP catheter was shown to provide satisfactory post-op analgesia after total shoulder arthroplasty, but the ESP group did have a 2.5-point higher median pain score in PACU, although subsequently there was no difference in pain scores post-op day 0 through 2. And the high thoracic ESP group also did have higher opioid consumption on post-op day 0, but again, there was no difference in cumulative opioid consumption through post-op day 2 after that. The benefits of the high thoracic ESP catheter over an interscaling catheter included no hemidiaphragmatic paresis or paralysis and less adverse events. So this study demonstrates that the high thoracic ESP catheter can be a viable alternative to the interscaling block, particularly in patients where any risk of phrenic nerve palsy would be concerning. Thank you.
Thank you, Lisa. And Sandy, why don't I send it up to you first if you have any questions. You may have to unmute your mic. But there are a couple of questions in the comments. I'll get to those in a second. But Sandy, you have any questions or comments about this one?
Yeah. Hi, Lisa. Nice job. So just a couple questions. The patients that had complications, were they all different patients, or was it 1 patient that had several of those complications?
Yeah, good question. So they were all separate patients.
Okay.
So basically 1 adverse event per patient.
Okay. And any of those side effects really troubling to the patients? Any of the hemidiaphragmatic paralysis that was symptomatic to those patients requiring any sort of treatment?
So the patient who had Horner syndrome did get a CT scan because of concern for stroke. The patient was then seen by the regional service and kind of counseled on the results of that, and we always tell patients pre-block that this is ptosis and Horner syndrome is a potential complication. And so they were not unhappy about it, but it did cost them, an additional imaging test. And then the patient with dyspnea was placed on supplemental oxygen overnight, but otherwise was not too bothered by that. And none of the patients, felt overall unsatisfied with their course.
How about the thoracic ESP? At what level did you place it, and what are some potential risk factors for that block that might lead you to not use that in a patient?
So we placed them at T4 or T5, whichever was visualized best on ultrasound. And then the process for placing it, we hydrodissected the ESP with 30 cc's of saline and then made sure that the catheter threaded very smoothly, at least 10 to 15 centimeters past the tip of the TUI. So if there was any resistance met, we would pull it back, re-image, re-inject saline to make sure we open up the space so that the catheter was actually threaded cephalad rather than curling up in the space. I would say that concerns in terms of doing this for certain patients would be, the patient being able to tolerate positioning. So we had patients positioned prone for this block. And then also after having done this study, knowing that they may have higher pain scores and may have higher opioid needs immediately post-operatively, so whether or not they would be able to tolerate that higher opioid use.
Okay.
Meg, any questions for Lisa?
I was just going to ask her opinion question. You used 12 mLs an hour of local anesthesia. Were you doing that as an intermittent bolus, or were you doing it as a continuous infusion? And do you think that had you chosen the other option, your outcomes might have been different?
Can you hear that, Lisa?
Oh, sorry, I think it cut out. So you said, was it an continuous infusion or automatic bolus? And then I didn't hear the rest of it.
If it was a continuous infusion, do you think that an intermittent bolus might have changed your outcomes?
Mm-hmm. Yeah, so we actually did do it as an intermittent bolus. And I think we felt it was important to do it that way to get the appropriate amount of spread in the fascial plane.
Thank you. Very good study.
And let me just throw in a couple of comments from the questions from the comment field here. So one was the 5 ml bolus in the PACU prior to assessment. For an ESP, do you consider that enough volume to get an effect when we know that's a large volume thing? And then the secondary question was why hemidiaphragm paresis was chosen as the primary outcome when you don't expect that to occur at all with ESP blocks. And so your primary outcome is not really something that's even relevant to that block itself.
So for the first question, the 5 ml bolus, so I would agree that you ideally would have a larger volume bolus for a fascial plane block, but we wanted to have it standardized between the two groups. And for the interscaling group, we just felt in terms of safety, it was better to have a compromise in terms of the volume rather than bolus too much at the interscaling. And then in terms of the second question, so I think that it's still somewhat a matter of opinion in terms of whether or not the high thoracic ESP blocks can cause diaphragm paresis. And so that's why we wanted to look at that, was to definitively or have at least better evidence in support of that statement. Because it, with imaging studies and whatnot with this block, it has been shown that it does stain the cervical nerve roots, which contribute to the phrenic nerve, et cetera. So I don't think that was a known fact.
Sam, why don't we finish off with one last question from you, and then we'll move on to the next poster.
Just one question?
1.5. You get rights to expand.
Right. Actually, I'd like to thank Dr. San very much. This is one of my favorite posters. And you said quite well why you couldn't do a third arm with a sham block, although all the patient had general anesthesia. So I would be dreaming about another study with a third arm sham, because we showed that there's no difference in pain control. There is no good pain control action in the PACU or post-op day 1 with the erector-spinal block. So maybe sham, although pain after total shoulder surgery is really, really horrible. I see those patients week, a month after the surgery, and they're really miserable. So knowing that the ESP can help, we can do it even later as a post-op. So my question for you to know if you really had block to the relevant nerves, did you do a sensory exam after the ESP to see if you have cutaneous block? Because if you didn't get a phrenic nerve, this means that you didn't get into the nerve roots. The phrenic nerve and the nerve roots are all in the same fascial compartment. They are all deep to the prevertebral fascia. So if you believe the medication will go medially, it will get the C3, C4, 5. Laterally, it will get the phrenic nerve anterior to the scalene muscle. So this is my question about sensory exam, because I believe if you are posterior, all what you're getting is the posterior nerve, which is the suprascapular nerve, which is joint analgesia, not necessarily cutaneous in the shoulder. You might get the dorsal rami. Mm-hmm. The second question before Raj cut me off is the power. You elegantly said the study was powered to 50% of the phrenic nerve. And you got statistical significance, so its power is perfect. However, anything that you couldn't find statistically significant thing, it could be because of the power. So I would say regarding the post-op 1 and post-op day, I would say you find a trend, significant trend towards not as good pain control and we fail to get statistical significance because the study is not powered enough, unless you do a post hoc analysis. So this is something would be very good. It's still there if you didn't report it, post hoc analysis, and if it's powered for the post-operative day one pain and opioid, then it would be great. I'm done.
Yeah, thanks. So I agree. I think a placebo group would be also interesting to have, but not possible. And then in terms of sensory blocks, so we were only able to do most of our measurements in PACU because just timing from after the block to patients getting into the OR. But after in PACU, because we didn't have much access to the shoulder, we just did sensory checks on the hand and it tried to do like C5 through C8 distribution. We did not have any sensory block to cold in the ESP group. And then, sorry, what was your last question? Oh, yes. And yeah, I agree. The power in terms of trend, it does look like they don't have as good pain control even after the initial day after surgery. Mm-hmm.
Lisa, thank you so much. We're going to move on to the next poster. I'm going to kick you out of the headshot here so we can get Tiffany on. But thank you so much for participating today.
Thanks.
Thank you.
And Tiffany, I'm going to get you on here. Hi, Tiffany. And you're still muted, by the way. And I'm going to put your poster link in the comments field. And this is poster number 714 for those of you who are interested. And Tiffany's going to be presenting on dose-response relationship of local anesthetic volume and diaphragmatic paresis following ultrasound-guided supraclavicular block. So we're in the same theme here. Tiffany, take it away.
Okay, thank you for having me. I just want to say I'm program director at Cornell, and this is one of our fellow projects. And my fellow can't be here because she's working hard in the COVID ICU. So I just wanted to thank her for that. So I will be presenting for her, and that's Hannah Lynn. So this project we really wanted to answer the question, is there any safe dose of supraclavicular block such that you can avoid hemidiaphragmatic paralysis? So we aim to generate a dose response curve for local anesthetic volume and hemidiaphragmatic paresis. So that was our primary objective. Secondary objectives were to assess respiratory function via negative inspiratory force and also oxygen saturation, and also the extent of sensory and motor blockade. So we enrolled patients in an up-down methodology type of trial, very similar to what's used for phase 1 dose-finding studies. And we enrolled 3 patients per cohort, starting at a dose of 35 cc's of local anesthetic. It was a 2-to-1 mixture of 1.5% mepivacaine and 0.5% bupivacaine. And if any of the subjects in that cohort demonstrated paresis after block, we would move down in the dosing by 5 cc increments. And then alternatively, if no patients exhibited paresis, we would move up in the dosing. We established whether hemidiaphragmatic paresis was present by using M-mode ultrasound tracings of the diaphragm, and they were recorded baseline measurement before sedation and block, and then 15 minutes after block during voluntary sniffing. The patient, for each time point, we would have the patient perform 3 voluntary sniffs, and then those ultrasound images were reviewed by 2 blinded investigators after the fact. Diaphragmatic paresis was defined for the study as greater than 60% reduction in diaphragm excursion during voluntary sniff. Also, no movement or paradoxical movement was included in the paresis designation. Bedside NIF meter was used to measure negative inspiratory force in centimeters of water at baseline, and then also 30 minutes after the block. At 15 and 30 minutes, we performed a motor and sensory exam. The combined motor sensory exam score was 20 being a complete block in all distributions assessed, and 0 was no block. We defined successful block as anything 10 or greater. And after we gathered the data, we fit this dose response data, fit with a non-parametric smoothing technique to generate the dose response curve. So we were able to enroll 24 subjects. 3 of which we excluded for baseline abnormal diaphragmatic motion. We found that hemidiaphragmatic paresis was present at all dose levels tested, and you can see that in figure 1. And enrollment was stopped per criteria when we observed hemidiaphragmatic paresis at the lowest dose. Figure 2 just gives a demonstration of the up-down methodology that we used starting at 35 cc's. All patients in that cohort had paresis, and then we moved down, and you can see how we generated subsequent dosing based on that. Of all of the patients, 14 patients had paresis, while 7 patients did not. And the patients with paresis had a statistically significant decrease in NIF 30 minutes post-block. That ranged anywhere from 40% to 100% of their baseline levels. The median was 80%. There was no difference in NIF in the patients who did not have diaphragmatic paresis. In terms of the motor and sensory block score, there were only 3 patients that met criteria for a failed block, 1 in the 5 cc group and 2 in the 15 cc group. And the way that we handled that, I should have mentioned, when we placed the nerve block, we used a catheter over needle catheter system to place a catheter. So if the patients had a failed block after the last evaluation, we were able to redose those patients appropriately, and none of the patients required conversion to general anesthesia. Also, none of our patients exhibited didn't need respiratory intervention. That's likely due to the fact that we enrolled patients without respiratory disease, so these were healthy patients. So in conclusion, we found that really there's no way to avoid hemidiaphragmatic paresis with a supraclavicular block. You can get it all the way down to a dose of 5 cc's. And we found that the up-down methodology we used was useful to minimize patient exposure to potentially sub-anesthetic volumes of local anesthetic while we were trying to answer this question. We found that M-mode was useful in diagnosing diaphragmatic paresis. NIF was also helpful in determining how the diaphragmatic paresis affected those patients. In terms of respiratory function, we found a decrease to about 80% of their baseline NIF. And in our patients free from respiratory disease, this did not require any intervention. One limiting factor to our study is that, just coincidentally, all of the patients except 1 were female. This doesn't affect our NIF endpoint because each patient was compared to themselves as a control, although we don't know if perhaps females may be more or less susceptible to diaphragmatic paresis from supraclavicular block than males. That's a theoretical concern, but in reality, that's probably not the case.
Excellent. Nabil, I'm going to start with you this time. If you have a question you want to jump in on, there's a bunch of comments in the comment field. We'll get to those in a minute. But Nabil, you want to start?
Yeah, sure. Stephanie, congratulations. This is like a very nice study. Okay, very
Oh,
well
thank
done.
you.
It's just, it's surprising, maybe just in my head or just my own belief, like when we do the supraclavicular nerve block, that we're at least trying to avoid the hemidiaphragmatic paresis. So when we see a study that you're assessing the diaphragm after each supraclavicular block, and you say there is no way to avoid like the hemidiaphragmatic paresis, this is almost kind of a awakening call that really the incidence is much higher than that we used to teach, like in our residents and fellow, when we said like it's about like 50% or less. But the other thing I'm going to ask you, like in your own practice, do you use about 35 cc, or what's the normal volume that we use in your own practice?
Well, in our practice, we use 25 to 30 cc's. There's an interesting study by Kant et al., which I think is in my references, where he found the ED95 for supraclavicular block to be 27 cc's. There's another similar study that found it to be 17 cc's. And generally, we try to do surgical blocks for surgical anesthesia, so we tend to be on the higher side.
Okay, and one more question. Did any of the patient, and I don't know if you may have said it, but I missed it, any of the patient were symptomatic?
No, we did a dyspnea scale, and two patients with hemidiaphragmatic paresis indicated very low levels of dyspnea, 2 on a 0 to 10 scale. And I do want to say in terms of where we did the injection, because I know a lot of the literature suggests if you're in the corner pocket or posterior lateral, you can avoid phrenic nerve blockade. We did require that the practitioners surround the entire plexus. Some of our surgeries were very proximal near the shoulder. So, it wasn't just done in the corner pocket, and that might have an effect.
Sam, we'll go to you next. Questions, comments about this poster?
Thank you, Tiffany, very much. This is really a great study, and I loved it because it should put to rest the idea that phrenic nerve paresis or palsy is a complication of interscalene block or suprascapular block. It's not. It has to happen. By ultrasound and our anatomy, it's a compartment block, what we're doing. It's a compartment block deep to the prevertebral fascia. So I think the take-home message to me is that you excluded 3 from the study because they have baseline phrenic nerve problem. So I think our role as an anesthesiologist is to risk stratification and prior to the procedure to see what's the phrenic nerve on the other side. If we have X-rays, we'll look at it to see if there is diaphragmatic paresis. But I think this is the point that I want to stress, that phrenic nerve palsy or paresis might be inevitable with any interscalene block. And so I don't have any other question rather than congratulations. This is really a great study. And again, from here, we can make a recommendation to check the opposite side first.
Thank you.
Sandy, any thoughts on this one? I know you guys do a lot of shoulders.
We do. No, I thought this was really interesting. I was surprised that you saw that you still continue to see the hemidiaphragmatic paralysis at 5 cc's. That surprised me. I wouldn't have guessed that. So I thought this was nicely done.
Thank you.
I'm going to just quickly throw out a comment. Dr. Harry Caligaro was asking, one, he made a comment of fact that acoustic windows are not easy on the left side. So it looks like you guys mostly, or you intentionally chose the right side for the purpose of ultrasound facilitation. I think you comment on that. He asked, and this is my own ignorance of point of care ultrasound, he said, why was the zone of opposition method of diaphragm assessment not used? I don't know if you can answer that question because I have no idea what that means.
We chose this method because looking at the ultrasound literature for diaphragm motion, it seemed like this was the most accurate to find variability in the voluntary sniff test.
I got it. Meg, before we move on to the next poster, any quick questions or comments?
First, I want to say hi, Tiff. How are you?
Good. How are you?
Can you describe I'm still stuck on the 5 cc's actually.
Okay.
You said you put the needle in, you injected, and then you threaded the catheter. Is that how you did this?
It's a catheter over needle, so you pull the needle out.
Okay, so it's like an IV, and you put the needle, so you can't inject along the way. How did you ensure that 5 cc's actually gave you breadth of coverage?
Well, you could move the needle. So the first injection was done in the corner pocket, and then we gave each anesthesiologist carte blanche to do injections, to make sure there was coverage around the complete plexus. And at 5 cc's, I actually did one of those. It was, a cc here, a cc there. And then we actually left the catheter where we felt would be the best coverage if it had to be redosed, because the redosing was going to occur after all the evaluations were done, if needed.
Thanks for the clarification. Very nice study.
Tiffany, thank you so much. I'm going to kick you out of our little head box here and bring Lynn on. But thank you so much for attending and getting present your poster. I appreciate that. All right. We've got Lynn up here. Hey, Lynn. Let me pull up. So we're going to be talking about poster number 770. And let me grab the link to put in the notes here. And we're starting to get a theme here with diaphragms and interscaling and upper brachial plexus blocks. That's going to be sort of consistent, and there's a theme going, whether it was intentional by the CME committee or not. There seems to be a theme. This one is called 10 milliliter normal saline washout aliquots are insufficient to reliably reverse phrenic blockade from interscaling nerve block. And I'm going to put the poster up here, and the mic's yours, Lynn.
Great. Hi, everyone. My name is Lynn Nye-Gerber, and I'm one of the current fellows at Stanford University. Dr. Sun and I actually overlapped in fellowship, so it was great seeing her talk today. Thanks for this opportunity, Raj, to share our research virtually. I'd like to present another randomized clinical trial performed by myself and colleagues at Stanford. And as we've all been talking about, the interscaling nerve block provides excellent intra-op and post-op pain control, but as we've been discussing, it's also associated with a higher rate of phrenic nerve blockade, which can lead to respiratory distress in those with and without underlying respiratory or pulmonary pathology. Our group has previously published case reports showing subjective and objective improvement of diaphragmatic paralysis in patients receiving not only single shot injections into the interscaling space, but also boluses of normal saline into their nerve block catheters, suggesting that these normal saline washouts may restore phrenic nerve function while preserving the nerve block's analgesic effect. So in this randomized clinical trial, we aim to unveil a new technique of using normal saline to wash out local anesthetic from the interscaling space to not only restore phrenic nerve function, but to preserve analgesia, with our primary endpoints being diaphragmatic excursion as a surrogate for diaphragmatic paralysis and pain scores. And then our secondary endpoints were brachial plexus, motor, and sensory function. IRB approval, clinical trial registration, and patient consent were obtained, and the patients were randomized to either the control or the treatment group. And to be clinically relevant and to set our power, we set the expectation that at minimum 3 out of every 4 patients, or 75% of patients who received the normal saline washout, should have reversal of phrenic nerve blockade. And so thus clinical significance was defined as a reduction from 100% incidence of phrenic nerve blockade in the control or sham group to a 25% incidence of blockade in the treatment or normal saline group. And so with a type 1 error rate of 0.05 and a power of 0.8, 8 patients per group were required to demonstrate significance. So as you can see in this little diagram, in pre-op, after the baseline measurements of diaphragmatic excursion, pain, and brachial plexus exams were taken, the patients received an interscaling nerve block per the regional team's protocol, and then underwent a general anesthetic for their shoulder surgery. And then in PACU, again, 5 cc's of ropivacaine, 0.5%, were given to reset the nerve block. And then we randomized participants to either receive 3 doses of 10 milliliters of normal saline if they were in the treatment group, or 3 doses of a sham washout. After which we took serial measurements of diaphragmatic excursion, pain scores, and brachial plexus, motor, and sensory exams. If you go to the ultrasound pictures, please, thanks. Calculating the diaphragm's excursion ratio allows us to see the degree of diaphragmatic movement, and thus served as a marker, an objective marker for diaphragm paralysis. So as an example, on the top 2 ultrasound images, you see a dramatic example of diaphragmatic excursion with deep inspiration on the left, and then expiration on the right. And those crosshairs demonstrate the location of where we took the measurements to calculate the diaphragmatic excursion ratio. Compare this to the second set of ultrasound images, the second 2 at the bottom, taken in the same patient 30 minutes after a bolus of ropivacaine via an indwelling interscaling catheter, which demonstrate an expected decrease in the diaphragmatic thickening and thus excursion, which is consistent with paralysis. So going to the results, we found no clinically significant difference in reversal of diaphragmatic paralysis in patients who received the normal saline or the sham washout. So if you go down to the bar graphs on the left-hand side, you see that all patients, regardless of group, remained with a paralyzed diaphragm, which was defined as a 25% or more decrease in the excursion ratio compared with their pre-block baseline ratio. However, if you look at the right side of those bar graphs with the orange, this is our sub-analysis stratifying the results by the degree of paralysis. And we did actually see a significant difference in the number of patients who ultimately displayed a partial versus full paralysis of the diaphragm after the washout. So partial was defined as a 25 to 75% decrease from baseline ratio, and then a full paralysis was 75% or more decrease from baseline. So this represents a difference in the degree of blockade between the two groups. So going up to the blue chart in the results, there is no significant difference in participants' pain scores or PACU opioid requirements in either group. And the secondary outcome measures also showed no differences in the brachial plexus motor or sensory exams between the two groups at baseline, post-intervention, or when comparing their individual change in exam scores. So this randomized clinical trial shows that normal saline washout in 10 cc increments has no clinically beneficial effect on reversing phrenic nerve blockade, but it may reduce the degree of blockade and also doesn't lead to a reduction in analgesic effect of the interscalene nerve block. So our previous experience in successfully reversing the phrenic nerve block in our case reports used larger volumes of normal saline, up to 30 milliliters. So perhaps our intent during this randomized clinical trial of potentially minimizing rebound pain from the washout by using smaller volumes of normal saline was insufficient to unveil a clinically beneficial effect. More patients in the washout group showed an improvement from full to partial paralysis, suggesting that perhaps a larger bolus dose of normal saline may be sufficient to completely reverse the paralysis. So further investigations might use this as a dose-finding study in determining the minimum volume needed to produce a reversal of phrenic nerve blockade while preserving analgesia. Thank you guys so much.
Thank you, Lynn. Meg, I'm going to start with you. Questions about this poster. I think the washout thing is incredibly interesting. But I'm really fascinated by the assessment tool. And before you get to your question, Meg, I do want to comment that we've had some really exciting conversation going on in the comments and by some very notable people, often faculty at our meeting. So it's great to see everybody participating today. So Meg, go ahead.
I was going to really ask you, did you come up with the 3 10 cc doses to mimic the 30 cc dose that you had in the past? And how'd you choose the time increment between which you gave those doses?
Yeah, so our ultimate goal was the 30 cc's to mimic the bolus that we had seen before that was successful in reversing the phrenic nerve blockade. But we decided to do it in increments just to potentially minimize potential rebound pain, even though we also knew that in our previous case reports, we didn't see any rebound pain. We just wanted to be extra safe, given that this was a clinical trial. So we measured diaphragmatic excursion ratio, pain scores, and the brachial plexus exam in 10-minute increments, each time giving 10 cc's.
And do you think this intervention changes if it's given a further time post-block, or do you consider that your 30 cc intervention is effective anytime post the block being given?
So we tried to standardize it such that after that PACU bolus dose of 5 cc's to reset the block, we gave that 30 minutes to kind of take effect. And then at 30 minutes, that's when we started the 10-minute intervals of bolusing 10 cc's at a time. I personally believe that if we had been given them that bolus dose of 30 cc's normal saline at any point of time after the block, it would have shown a more beneficial effect of reversing the phrenic nerve blockade.
Thank you very much.
Thank you.
Sandy, you want to do a follow-up question?
Go figure, they would pick this 1 hour to bury my internet cable, which apparently just took my internet out. So
Oh, no.
I apologize that I flashed out and came back in on my phone. Thank goodness for data. Yeah, actually, I would never even have thought that this would work. I think this is really, I think this is super interesting. I did miss part of your part of your presentation, so I don't really have any further comments.
Thank you.
Sam, you want to try? I know Sandy cut in and out there, but I think you heard most of it.
Sure.
Yeah.
Yeah, this is a very interesting study because honestly, I was not aware of those couple of case reports. When I read it, I was like, why they want to study something like this?
Yeah.
Is it because local anesthetic blocking the sodium channels? So we want to give normal saline and some sodium bathing the nerve, or you want to push the local anesthetic that you have even further to get more into the phrenic nerve? I was surprised by the concept. It makes sense, but I'm concerned that maybe you are opening more compartment syndrome, more compartment. You are separating the muscles apart, and the next bolus with local anesthetic might reach to the phrenic nerve if it didn't reach it out already. So it was a very interesting concept, and I enjoyed reading it.
Thank you. It was based off of epidural studies of washing out an epidural. Actually, that was, I think, a few decades ago that was demonstrated. And it was actually just anecdotal that one of my mentors noticed that giving normal saline through the intersaline space had a beneficial effect on one of his patients who had respiratory distress, which is why we pursued this subject.
Thank you.
Yeah.
Good.
And Nabil, any final thoughts or questions before we move on to the next poster?
No, it's actually a very interesting thought. Like, we always talk about how to make the block very effective and how to really make it dense, but we never thought about reversing the block. So I think that idea in of itself is interesting. And I saw in the live comments, if you don't mind, Raj, I saw a comment from Max. He was talking about maybe trying that with something like intralipid. And I would just chime in and I would tell you that we have started from some work, but unfortunately it never came to fruition, and we never completed that study in an animal model. We actually used to inject alpha-2 blockers. We used to inject phentolamine because if you think about it, when you want a block to last longer, you use epi. Okay, so when you use phentolamine, the resulting vasodilation may actually cause a very similar effect to the washout of the normal saline. And actually, we would be surprised if you take your child to the dentist and they give them local anesthetic and their lip is numb. The next thing that they do, they give you a cream so the kids are not going to be biting their lips. And that cream that they put on the lips is actually phentolamine. And the phentolamine, the idea is they would reverse the effect of the local anesthetic. So we thought of just injecting phentolamine through the catheter to reverse the local anesthetic. We did that in an animal model, but for essentially the lab that we're working on just essentially got canned, and we never completed that work. But I think it's an interesting idea.
Yeah.
Great. Thank you so much, Lynn. And Lynn and Tiffany, both of you guys are welcome to stay and watch and participate. But if you have to step away, that's fine too. I know Tiffany's still out in their wings, but we're happy to have you guys here. We're going to move on to Andrew. And let me pull his up. Andrew, welcome.
Thank you for having me.
And let me get your poster. I'm going to put your link up on the comment stream. And this is poster number 828, entitled Mepivacaine versus hyperbaric bupivacaine versus isobaric bupivacaine, spinal anesthesia for early ambulation after total hip arthroplasty. And this is a randomized controlled trial. And Andrew, this is we seem to be focusing on local anesthetics primarily today, so go for it. Perfect.
All right. So as Dr. Gupta said, my name is Andrew Mendelson. I'm a CA3 at Thomas Jefferson in Philadelphia. My abstract was mepivacaine versus hyperbaric bupivacaine versus isobaric bupivacaine for spinal anesthesia for early ambulation after total hip arthroplasty. So total hip arthroplasty is one of the most successful and common operations in the U.S., performed either under general or spinal anesthesia. Some of the benefits of spinal anesthesia can potentially be drawbacks for some same-day discharges. Most commonly, we see impairment of sensory and motor function that limits early ambulation and delays discharge. One of the delays we see at our institution is a lack of patients being able to participate with physical therapy postoperatively, and we want to work on try to improve this. Most commonly at Jefferson, we're using bupivacaine for spinal anesthesia for total hip arthroplasties, and that comes in two forms, hyperbaric and isobaric, and that produces a partial motor blockade that can last 2.5 to 3 hours. We wanted to compare this to mepivacaine, which is a intermediate acting amide local anesthetic, which also is used for spinal anesthesia. This lasts about 1.5 to 2 hours. There were previous retrospective studies that looked at total knee arthroplasty, and they suggested mepivacaine for spinal anesthesia allowed for earlier ambulation among the group. So we hypothesized the greatest number of patients would ambulate early with mepivacaine, followed by hyperbaric bupivacaine, and finally isobaric bupivacaine. We got IRB approval, and the study took place at Thomas Jefferson University Hospital and Rothman Orthopedic Specialty Hospital. Inclusion criteria included ASA physical status 1 to 3, patients under the age of 85, scheduled for primary elective total hip arthroplasty, and could walk 10 feet without human assistance. Patients were randomly assigned by a computer-generated sequence to receive either mepivacaine, isobaric bupivacaine, or hyperbaric bupivacaine for spinal anesthesia. All patients received standard multimodal analgesia consisting of preoperative gabapentin or pregabalin, acetaminophen, and either celecoxib or ketorolac, which was continued for 48 hours. Study took place with 3 orthopedic surgeons who routinely perform elective total hip arthroplasties in under 90 minutes. Primary outcome was the percentage of patients who could ambulate at 3.5 hours after spinal anesthesia placement in each group. We chose this time because previous studies reported ambulation time after mepivacaine spinal anesthesia at 212 minutes. Physical therapists who were blinded to assignments tested patients for ambulation between 3 and 3.5 hours, and then every 2 hours after that if ambulation did not occur previously. Patients were blinded, but the anesthesiologist and resident or CRNA performing the spinal were not blinded. Secondary outcomes included return of motor and sensory function, urinary retention, transient neurologic symptoms, hypotension, length of stay, pain intensity, and opioid consumption. Secondary outcomes were assessed by blinded study investigators as well. 154 patients were enrolled, 50 patients received mepivacaine for spinal anesthesia, 55 with hyperbaric bupivacaine, and 49 with isobaric bupivacaine. No differences in patients' age, BMI, sex, or ASA physical status between the groups. No differences in distribution of surgeons or surgical approach among the groups. Primary outcome of ambulation at 3.5 hours. The greatest percentage of patients met this endpoint in the mepivacaine group, followed by hyperbaric bupivacaine, and then isobaric bupivacaine. Patients who received mepivacaine were more likely to ambulate at 3.5 hours compared to the other two groups. Secondary outcomes, mepivacaine had a shorter length of stay compared to the other groups, and more patients in the mepivacaine group were discharged on the day of surgery. Patients in the mepivacaine group had higher pain ratings and opioid consumptions in the PACU only. And there was no statistically significant differences in other secondary outcomes. So our study demonstrated spinal anesthesia with mepivacaine allowed for earlier ambulation after total hip arthroplasty than either form of bupivacaine. This came at the expense of increased pain and opioid consumption in the PACU. However, this was only present in the early postoperative period, and it wasn't surprising given the shorter duration of action of the mepivacaine. Our work, we felt, improved upon previous work because we attempted ambulation earlier after surgery at a time when differences in motor and sensory function would be apparent. In conclusion, patients who received mepivacaine spinal anesthesia were more likely to ambulate early and be discharged on the same day. And this actually changed some surgeons' protocols at our institution. And we're using mepivacaine more routinely for spinal anesthesia for total hip arthroplasties.
Thank you, Andrew. I'm going to take the privilege of asking a couple of questions because we've been using mepivacaine for quite some time for our total hips and total knees and been very satisfied with it. I was surprised to see that you guys had a 10% incidence of transient neurologic symptoms. How did you guys define those, or how did you assess those? Because that usually is picked up much later, not in the immediate postoperative period. And my second question, and I may have missed it, was what was the dose of mepivacaine you were giving?
So for your first question, how do we picked up on TNS? We would call them post-op day 1 if they weren't in-house, and follow it up as well as post-op day 2. And a lot of the questions were just like any back pain and things like that. And, if it might not have been true TNS, but if they had any possible symptoms, we counted that as TNS. And for your second question of dosages for mepivacaine, we gave, it was 1.5% when we gave 3.5 cc's. And then for hyperbaric bupivacaine, it was 0.75%. They got 1.5 cc's. And for isobaric bupivacaine, it was 0.5%, and they got 2.5 cc's. For patients who were taller than 74 inches or at a BMI of greater than 35, we gave an extra 0.5 milliliters of whatever they received, local anesthetic for their spinal.
Sandy, I saw you nodding over there. I don't know if you were nodding about the TNS question or the dosing question.
Both a little bit. I think it's hard to say TNS if it's just back pain because, a lot of people have DJD, and just laying in bed like that after hip surgery can cause a lot of different pain. So that's one thing. The other thing is I was just trying to decide if I thought really that those doses were equivalent. I mean, obviously you're trying to minimize the motor block. That dose of bupivacaine seems kind of on the high side to me. So I just wonder if that might have been part of the reason. Also, are your hips done lateral or supine?
So 2 of the surgeons perform direct anterior approach, and the third surgeon does a anterolateral approach.
Yeah, you're talking about the hyperbaric bupivacaine and the implications of that in a lateral or even a bumped position may affect your quality of your block.
Right.
Yeah. I'm going to put a comment up here. Eric Schwenk was obviously the mentor on this paper, and he said it was a very specific question from a prior study. Do you have any pain not present before surgery that is in your back, buttocks, and goes into thighs? Yeah, I wonder if people heard that as and or. If you have any back pain or in your buttocks or thighs, or it has to be all of the above. Because there are other studies that show much lower rates of TNS with mepivacaine, and 10% seems like an unacceptably high number if that's truly the case. And we have not, at least we haven't actively looked for that, but at least anecdotally we have not had anything close to that, and definitely not a functionally impairing TNS with mepivacaine. And we've been doing it for 5 years now with mepivacaine. Sam, any questions, Andrew, for this spinal?
Thank you very much, Andrew. It's a nice study. Actually, you got my question. Everyone got my question. I was really, really surprised with this 10%.
Yeah.
I don't think we can do something that happened 1 in every 10 patients. I might believe that it could be a back pain prior, because it's very common for patients with hip pain and back pain to have it simultaneously, and they don't know which is which. Usually those patients present to back pain, and then when we do x-rays and work up, oh, it's your hip more than back, but they have some back. So maybe you used a looser criteria for the TNS, but 10%, it's surprising and it's alarming.
And just to chime in from Eric again, he said that they're asking specifically, and if I interpret his comment, I'm wondering if it's when you're seeking it out, you're finding the low level symptoms and you're going to get a higher incidence. Meg, any questions for Andrew?
I'm stuck on the TNS also because there was a 10% incidence in the hyperbaric 1.5 cc's, which means that 1 out of every 10 of our laboring patients who had C-sections would also be experiencing that. So I wonder if the question was interpreted differently than it was asked. And again, I was going to say what Sandy said, that those are much higher doses of bupivacaine than I'm used to doing for my patients that are ambulatory.
What are you doing? What doses are you using?
Basically, they are as per surgeon. My guys who can do them in under 90 minutes, I'm giving 1.2 cc's of hyperbaric bupivacaine, and I gave up isobaric bupivacaine a long time ago because old people and isobaric bupivacaine equals forever cane. So I usually think it's 1 cc an hour that I need. So, and I don't know, but I liked your pictures, especially the bladder. It was cute.
Thanks.
Thanks for a nice study.
Yeah, you definitely get the feeling of urgency on that picture of urinary urgency. Nabil, any last thoughts before we go to the next poster?
Yeah, congratulations. Very nice job.
Thank you.
Yeah, I just have a question for you and Eric and Chris, if they are able. Actually, we tried to do a study similar to that, and believe it or not, we got pushback from the IRB regarding the use of the isobaric. Because the isobaric, like bupivacaine specifically, it says, like, not for use for spinal anesthesia. And they give us we're still, like, going back and forth with the IRB people. So how did you guys, like, get around this?
For the isobaric bupivacaine?
Yes.
That was prior to this study. That was our standard of care. We were using the isobaric bupivacaine.
Yeah, but you enrolled patients, right?
Mm-hmm.
Okay.
Yeah, that's something Eric or Chris might be able to better answer.
Yeah, we've run into that same issue, and the bottle. I mean, every few weeks I get the question, but the bottle says I can't use it for this, and
correct.
And that's a
But
struggle
you know
that we deal with.
Only 4% got TNS.
Right. Seems to be the safest of the three options. And Eric is mentioning on here that it was substantial literature basis for using it and decades of studies support its use. So maybe how the IRB interpreted those studies in the context of this research paper and the standard of use before that. Andrew, thank you so much for joining us. I really appreciate it. Eric and Chris, thanks for chiming in and filling in the details. It's hard to get everybody involved, but I really appreciate everybody participating. We're going to move on to Desmond here. I'm going to take Andrew off. Add Desmond. Desmond, thank you so much for waiting.
Hi, everyone.
We really appreciate you participating. Let me pull your poster up here. This is poster 1055, and I'm going to put the link in the notes if I can find the right link. And I do want to give you... I noticed on your poster, and I didn't know this beforehand, that this was partially funded by a graduate student award from ASRA. So it's good to always see those awards come back and be presented as papers or abstracts and see that money being used for good work. So let me put your poster up here, then you can take it away and describe your work.
Great, thank you, Dr. Gupta. Well, yeah, before I begin, I just wanted to take this opportunity to thank ASRA for the honor of the Graduate Student Award, as well as this unique opportunity to present our work on this online platform. So since this is a preclinical basic science study, I'll start by providing some context as it relates to the clinical relevance of this project. For many anesthesiologists, including yourselves, daily work likely involves management of postoperative pain. I think that there is agreement in the field of regional anesthesia that it would be helpful to have a local anesthetic agent that provides long-lasting pain relief after a single shot. Of course, with the current opioid crisis, there is a further emphasis on the real need to find non-opioid analgesic alternatives. That said, current local anesthetic agents like lidocaine, are limited in duration and can produce undesirable motor blockade that could hamper postoperative recovery. Although efforts have been made to extend the duration of a local anesthetic block produced by anesthetics, such as the use of adjuvants or innovative liposomal formulations.
Hey, Desmond, I'm going to interrupt you for just a second. I think your mic wire is rubbing on your shirt.
Oh, sorry about that.
It's causing a lot of static, and so I want to make sure people can hear you properly.
Okay, I'll just
try
that.
Out. Yeah, try that. See if that works better.
Yeah, so as I was saying, local anesthetics are limited in duration, and this can produce undesirable motor block. At our group at UBC, led by Dr. Stefan Schwarz, we've been working on quaternary derivatives of lidocaine, and we found that QX314 in particular produces long-lasting local anesthesia after a peripheral injection in mice. However, two notable issues came up during the course of study, as we found that QX314 produces robust motor blockade and also has a superior toxicity compared to its parent compound, lidocaine. It turns out that there are other quaternary lidocaine derivatives, and so the work presented here aims to answer whether QX572 and QX222, the other quaternary agents, also possess local anesthetic effects, and more specifically, whether they produce long-lasting motor blockade. And so we hypothesized that similar to QX314, these two other agents would also produce a long-lasting motor blockade. Now, to investigate this, we performed a series of randomized, controlled, and blinded in vivo studies in mice. And we used a rodent sciatic nerve blockade assay where we injected a small volume of a quaternary derivative into the popliteal fossa of the left hind limb. We then subjected these animals to a simple motor task that involved climbing up and over an inverted apparatus. Our primary outcome, motor blockade, was defined as the inability to use the injected hind limb. So if I can draw your attention now to the center figure, for this study, our reference compound was 70 millimolar lidocaine, which is equivalent to approximately 2% lidocaine. We found in this assay that lidocaine produced motor block that lasted up to 30 minutes. At equal molar concentrations, QX314 produced motor block that lasted almost up to 2 days. In contrast, the duration was a measly 10 minutes for QX222. Now you'll note that at around half the concentration, the third quaternary derivative, QX572, produced motor block up to a day. Based on these results, our key finding was that unlike QX314 and QX572, QX222 does not produce long-lasting motor blockade. And if you'll look over on the top right-hand side, these are group survival curves that indicate that these quaternary agents concentration dependently produce a motor blockade in animals. And in the table below, you can see the estimated potencies of these agents, indicating that between the three quaternary compounds, QX572 is the most potent, followed by QX314, and finally QX222. And so moving into a more general discussion now, what we suspect is that the observed pharmacological differences are likely due to chemical structure differences between these quaternary agents. From a clinical point of view, I think that it would be desirable to have a compound that has great sensory motor separation. And in this case, the finding that QX222 does not seem to possess long-lasting motor blockade may make it a good compound, a good candidate for further study. And so with that, I'd be happy to hear what you all think.
My mic. Thank you so much, Desmond, for presenting this research. I'm going to start with Sam. Sam, before you got on, Desmond, honestly, we had questions about this study, partly because I don't think we're as intelligent as you are in understanding what the science behind this, but your explanation was excellent. Sam, you want to start with the questions here?
Now you are starting with me, huh?
Now we're starting with you because you're the smartest of the group here, I think.
So first of all, thank you very much and congratulations. I just heard that you are just defended your PhD.
No, it was my master's. This is my master's.
Was it related to the same topic?
Yes, it was.
Okay. So it will be tough to find questions for you there. But this is great to understand. Basic science is the step one for us to understand. To have a molecule with differential block like this, it would be really great. My question to you, you might notice during this study, we always think from pharmacological point of view that the onset is something related to different pharmacokinetics parameters, and the potency and duration is something else. So did you notice any difference or negative points regarding the onset with this 222 molecule?
Right. So Actually, this is part of a companion study. We actually have a poster on investigating the sensory blockade and toxicity of these quaternary agents. And in that sensory assay, we found that there was a delay to onset produced by these quaternary agents, which comes intuitively as these compounds are positively charged. So it's likely that it would take a while for these compounds to diffuse across the biological membrane to produce its effect.
Can you make a comment about toxicity, and did you ever study the toxicity of those and reversal of them with the intralipid?
Yeah, so with QX572, it is the most potent quaternary agent. And with that compound, we found a robust local tissue toxicity in the form of ischemic necrosis. And with the other two quaternary agents, the QX222 and 314, we actually found incidences of death upon peripheral injection, which led us to speculate that this may be due to local anesthetic-induced systemic toxicity.
Or maybe neurotoxic? Did you study the neurotoxicity from those molecules? They are potent molecules or compounds.
We did not look too deeply into the neurotoxic profiles of these agents. We did perform histopathological analyses of muscle tissue. However, our staining technique was unable to detect real significant differences in neural tissue.
Thank you. Great.
Meg, you want to do the follow-up?
I was going to ask where the next study is taking you with these agents.
Yeah. So, like I said earlier, we found incidences of death, which raises the suspicion of systemic toxicity produced by these agents. And to study this further, we collaborated with the BC Center for Disease Control, and we developed a novel liquid chromatography method to detect and quantify how much of these agents are absorbed systemically. And so the next question would be to determine the cause of death, whether it be from central nervous system depression causing respiratory depression, or perhaps cardiac toxicity. So that's the next direction.
And are we looking at a time course where this could potentially be clinically useful to us?
That's hard to say.
It's a long way off, I'm sure. Some of these have to go through a lot of safety testing. Sandy, any questions about the this preclinical trial?
No, I think Meg kind of asked the question I was going to ask, which is, when you find that they cause death, what do you do? Do you just give up, or do you try to sort through it in another way? So I think you already answered my question.
Nabil, any questions? I have one, but I want to give you a shot here first.
No, you go ahead. I mean, I don't have any. Congratulations, Desmond. This is very nice, and congratulations to you and your team.
Thank you.
Yeah, I want to thank you for coming on and sharing this. Question I had that occurred to me when you said that these are all very positively charged ions, is that routinely we're trying to neutralize local anesthetics to speed onset with things like bicarbonate and stuff. Have you guys tried to see if you can drive the onset faster using a mixture of substances, but then still get the duration that you're seeing with some of the longer acting? Even if it causes a motor block, there may be value in a fast onset, super long duration agent. Of course, that didn't cause death, but leaving that part aside.
Yeah, so we haven't tried mixing formulations of these quaternary agents or adding, like you said, adjuvants like bicarb or perhaps epinephrine to these injections, but that might be one avenue of further research. I think back to an earlier question as to the timeline of these of the study. I think what we found can provide some sort of direction as to what parts of the molecule we might want to change to change these pharmacological effects, as you said, with rapid onset, probably reducing toxicity. That would be one thing. So the ability for us to make comparisons between these effects and also look at their chemical structure is of particular interest.
Yeah, that direct relationship, once we can sort of almost design or engineer these local anesthetics to target what we want and none of the bad stuff, that would be, I think, the holy grail of what regional anesthesiologists have been looking for years and never quite found the perfect solution. Thank you again, Desmond, for presenting your work. I think we're going to wind up here at the end, but I appreciate you coming on and presenting this wonderful poster.
Thank you, everyone. Thanks so much.
Thanks.
Thank you.
All right, everybody. So I think those came out really great. I was really happy with everybody being able to present their own work instead of us having to summarize and just talk about somebody else's work. I hope you guys enjoyed it as well. We had a really robust conversation in the comment stream, so that was interesting to watch. And I want to thank all of you for attending and being co-moderators with me. I hope you enjoyed it as well. As I've said at the end of every one of these, I'm wistful and missing the in-person meeting for ASRA because I look forward to it every year, and this is about the next best thing that we can get. So we'll take what we can get for right now. But I look forward to seeing you guys again in person soon, hopefully not too long in the future. And stay safe, everybody. Thank you.
All right. Thank you
Thank you
very
very
much.
much.
Thank you.
Bye,
Thanks,
everyone.
everybody.
Bye-bye.
All right.